Hi, everyone. Welcome back. Today, we're joined again by Dr. Stenehjem to talk about our infectious disease update for COVID-19 and what's been happening in the state of Utah. Eddie, as always, thanks for joining us.
Thanks. Good morning.
So I want to talk about case counts. Again, this is yesterday's data, as always. So as of yesterday, the state of Utah had 30,891 total cases, with 233 deaths and 1,913 hospitalizations. Our case count yesterday was 413 with 7 reported deaths. I want to talk about a little bit about what those numbers mean and how our hospitals are doing as well.
Yeah, thanks, Amanda. So interesting, the past 2 reported days, so yesterday and the day before that, had lower case counts compared to the trend that we had been on. You know, right now it's hard to say whether or not that is a reporting artifact, just meaning that our labs haven't reported in the data yet for those past 2 days, or if there's been any kind of hangups in terms of lab capacity. So we're going to have to really wait and see whether or not these past 2 days are actually indicative of our true case counts. If we ignore the past 2 days and look at the trend before that, we've clearly had a rising increase in cases, and we topped out last Friday at over 860 cases. And so I think right now it's still too early to say if we're seeing a leveling or a decline in case counts. I think that's going to really be kind of telling in the coming days, and to determine whether or not this blip of a decrease is actually due to a true decrease in community-based transmission, or if this is actually just a lab artifact that we worry about when we have such a dynamic kind of lab environment right now in terms of supply and supply chain and those types of things. So to be determined on that. But we may be seeing a leveling, but again, I don't want to be too definitive on that because it's too early. What we're seeing from a hospitalization standpoint is a plateau. And so right now we've had this big increase in cases in our hospitals, and as of yesterday, we had 159 patients hospitalized in the Intermountain Healthcare System, across our 23 hospitals. And that number has really kind of now stayed steady, starting back, around July 28th is really when we've kind of leveled off. Keep in mind that hospitalizations lag typically 7 to 10 days after a positive test. And so all of those positive tests we saw on Friday, those 860 plus positive tests, those will reflect hospitalizations really starting now and into through the weekend. And so right now we're plateaued, we're safe, we're able to maintain and provide excellent care to our patients with COVID-19. It's really going to be now telling what's going to happen after that surge and moving forward in terms of our case counts, in terms of our hospitalizations.
And as far as the death rate goes too, it seems like it's gone up a little bit. I don't know if that's correct. Can you talk a little bit about that, and also the fact that there's still the lag between case counts to hospitalizations to deaths, and that they're not all going to match up the 100%. So that 867 cases, probably we won't see deaths for a while. Is that correct?
That's absolutely correct. So a couple things are going on in terms of death rates. One, we are seeing an increase in deaths in the past few days, and that's very clear on the Utah Department of Health website. So we are seeing a few more deaths than we had seen previously. And so in terms of kind of the progression of COVID-19, you get exposed, you have an incubation period of 5, 7, up to 14 days. That's when you test positive. After you test positive, typically people don't get hospitalized for another 5 to 7 days. And then after hospitalizations, people don't typically die or succumb to COVID-19 for a number of weeks. And so many times these people will come in, get supported, get put on the ventilator, and may remain on the ventilator for weeks at a time, and then pass away, unfortunately. And so our death rate lags well behind our case counts. And so if we're seeing case counts of 867, and we want to say, when are those deaths occurring from those cases, you have to look 3-4 weeks down the line to actually make any kind of judgment based on those case counts. That's how most people are going to pass away from this infection if you are in a hospital. Granted, there's some, especially those in long-term acute care facilities, nursing homes, that they decide that going into the hospital is not, something that they want to do. They've come to a point where they don't want to seek advanced medical care. Those people die much quicker. And for that, you really have to look at outbreaks in nursing homes to really account for the deaths in nursing homes, because some of these elderly people have said, and it's their values to say, listen, I don't want to go to the hospital anymore, and they're going to pass away much quicker. So it's really that combination of the nursing home outbreaks and the hospitalizations to look at death. So it's a very complex and moving target. The other thing we have to really, understand is that, we're having this increase in cases. When you look at who's getting infected, the people that are increasingly infected are those that are between 25 and 44. Those people are at lower risk of death than those that are above age 65. And so naturally you're going to have a lower case counts, but they still end up in the hospital. And so we're still taking care of patients that are in their 20s and 30s and 40s routinely. And they're sick. And I can tell you, it's not a nice experience to be sick in the hospital with COVID-19.
I want to touch really quickly on something really specific about the deaths again. There's been a lot of controversy or question about how a COVID death is reported up through to the CDC. And I don't know if you can speak to this specifically, but if someone has an underlying condition, but they are admitted for COVID-19 and they pass away, they succumb to their symptoms, that counts as a COVID-19 death, correct? Because ultimately, COVID-19 is what, unfortunately, they passed away from.
Yeah, you have to look at what is the primary etiology of their death. And in cases in people that have underlying comorbid issues, they are at higher risk of death, and they're at higher risk of progressive COVID-19 disease. So worsening lung disease, requiring a ventilator, requiring advanced level of care. And so COVID-19 is their cause of death. If somebody comes into the hospital and they come in with an acute myocardial infarction and has no signs of COVID-19, we're not testing those people. So, we really want to make sure that people understand the ones that are cause of death are due to COVID-19. This isn't, an artificially inflated number because we just tag people with a diagnosis of COVID-19 that potentially die from some other cause, trauma, for example. So the people that are dying of COVID-19 are dying because of their disease, because of this infection that they have.
I think that's really important to note that, yes, someone might have an underlying health condition, but the reason they typically ended up in the hospital was because of COVID-19. They could have been perfectly fine and lived for a lot longer if they'd not gotten COVID. So I think that's super important, especially when you're reading things online and looking at different studies that are being put out. Just keep that in mind, that the numbers are not being inflated there's no reason for us to do that. It doesn't really help us at all. So just important to look at.
Right.
I want to talk about the contagiousness of COVID-19 really fast too. Someone last week asked us how long people are contagious after they test positive for COVID, and the fact that someone could have symptoms for weeks and even months, and are they contagious during that entire time? How does that work?
Yeah, it's a really complex topic that has a lot of subtleties, so I think it's good for us to talk about it. The CDC has definitions about when people can go back to work and when people can start engaging with their communities. And Intermountain has adopted those definitions for us as well. There's a few circumstances where we talk about a different modality that we do that, which we'll talk about in a second. So the CDC says when somebody gets infected, gets a diagnosis of COVID-19, they can go back into their communities and back into work once they fulfill 3 criteria. One is that there's 10 days that has passed from the diagnosis and your onset of symptoms, that you have improving respiratory conditions. Okay, so improving respiratory status. That doesn't mean your cough has to be gone, but that it's improving. And the last 3 days, you have not had a fever without the assistance of Tylenol or ibuprofen. And so if you fulfill all those 3 criteria, it's been 10 days since your symptom onset, you've had improving respiratory symptoms, and you haven't had a fever for the last 3 days without the use of any kind of antipyretics or Tylenol or ibuprofen, then you can go back and engage with the community or go back to work. So that is a non-test method for you to go back into your communities. Okay, and that's what we use with our healthcare workers and how we advise our patients in terms of when they can come out of self-isolation. The important point of that is that it's not a test-based method, and there are some people that have called for a test-based method where you do a swab of the nose to see if the virus is gone, and if it's gone, then they can go about in their community. The challenge with that method is that this virus can remain in your nose for weeks to months. And it remains in your nose at very low viral concentrations. And at that point, that virus is not viable, meaning we can't grow it in viral culture, which means that you are not contagious. What you're detecting is essentially dead RNA from the virus. Okay, so people, we've seen this in the hospital, have been positive for months, and they're just shedding this virus, the RNA of this virus, but they're not contagious. And so we really focus on the CDC definition of when you can engage and go back to work and when you are not contagious. So it's 10 days from symptom onset, improving respiratory conditions, and no fever for the past 3 days. If you meet those 3 criteria, then you meet the definition to go back and engage with your communities. We don't recommend a test of cure, a test at 10 days or such, because inherently many of them are going to be positive because of this prolonged viral shedding, and it's just going to lead to people in quarantine and self-isolation much more. But it's a really challenging topic. We sometimes have to do the test-based method in hospitalized patients because some of the nursing homes, so if we're sending a patient back to a nursing home, some of the nursing homes in the city require 2 negative tests. And for us to do that, many times these patients are in the hospital for weeks waiting for 2 negative tests because they just continue to shed the virus. I hope that helps. It's a very nuanced topic.
And also, because coronavirus, COVID-19 is so new too, we still don't know what the long-term effects of COVID are either. So I know that there was a case, I do believe out of Chicago, where a perfectly healthy woman had to get a double lung transplant because of the effects of COVID. So yes, you might not feel contagious or know that you have any long-term effects, but in a couple of years, there is the possibility that you will have these effects still. So I think that's important to look out and kind of do a self-body check of, am I still experiencing this? I'm probably not contagious, but maybe I should take it a little bit easy with everything else that I'm doing.
Yeah, and there's a report just out about patients discharged from the hospital for COVID-19 and looking at longer term symptoms. And the majority of people still had some lingering symptoms as a result of COVID-19 at 4 weeks after discharge. And so we know that there are going to be some likely prolonged symptoms of COVID-19. And it's just going to take time to figure out what those are and what that post-infectious COVID-19 syndrome looks like. And the most severe, those that have been on a ventilator or even ECMO or extracorporeal membrane oxygenation, where they have severe lung disease, we have yet to know what is the long-term damage of that infection on those lungs. It's most likely going to be pretty severe.
I want to talk a little bit too about testing again. Again, last week during our Facebook Live, someone asked the question of why we aren't testing people as soon as we know that they've been exposed. So if you live with someone who tests positive, why are we not testing that person immediately to stop the spread? Can you speak a little bit about how that works and why we don't recommend that?
Right. So, let's just take an example in a grocery store. If you are walking the aisles in the grocery store, you stop and have an unprotected engagement with another patron, meaning you're not wearing a mask. And then you find out that patron was COVID-19 positive, you're going to test negative. Okay. And you're going to test negative immediately because you haven't had time for that virus to incubate in your upper respiratory, lower respiratory tract to make a test turn positive. That incubation period is the period where you get exposed to when you become symptomatic. That incubation period on average is between 5 and 14 days. And so if you test too early after exposure, you're going to have a false negative test because you haven't had time for that virus to replicate in your respiratory tract to a degree where it's going to turn a test positive. And so once you've been exposed, you really have to wait at least 5 days, ideally 7 days, before you get a test. Because if you test too early, you're going to be most likely negative just because it's too early in the disease process. And so that's why it's really important to wait that 5 to 7 days before you go get a test if you've been exposed.
And I'm assuming if you think you've been exposed that you should probably self-isolate too until you get that test. Presume that you are positive. Don't go out to the grocery store. Don't go interacting with people. Act like you are positive until you can get that confirmation. And if it ends up being negative, that's great. At least you were potentially protecting those people around you as well.
Yeah, so that's actually a quarantine period. And so if you've been exposed, you're absolutely 100%. You want to quarantine yourself to prevent any ongoing potential transmission to anybody else.
So we're going to get to schools now. I've gotten a lot of questions on the Facebook Live. And I just want to point out, you're not a pediatrician. So you are an infectious disease physician. You know a lot about this disease, but we'll probably end up speaking with a pediatrician specifically maybe next week just to get a little bit more specifics. But I want to talk about a question that's come up a lot. People are saying that there's no evidence that children are getting sick or that they can be a carrier for COVID-19. Therefore, why do they have to mask their kids when they go to school? And also that there's been no cases of COVID-19 children being hospitalized, specifically in Utah. Can you speak a little bit about what you know about that?
Yeah, so I mean, just looking at our state data, there's been over 2,000 children that have been diagnosed with COVID-19 via standard, nasal testing. And so that's 2,000 kids that are 14 years of age or younger that have been positive. We've had a number of children up at Primary Children's Hospital that have been hospitalized due to COVID-19. Fortunately, it's not to the degree, the hospitalizations that is, it's not to the degree as adults. And I mean, if there's one, silver lining in this infection is that it does not impact our children to the degree it impacts adults. And if children were getting sick at the rate of adults, I think this would be a very different conversation. But fortunately, that's not what we see. We see that children are doing pretty well with some rare circumstances of children needing to be hospitalized for COVID-19 or due to the complications of COVID-19, that MIS-C syndrome that we've talked about in the past. So let's quickly dispel that. Children can get this infection and some kids can get severely ill from this infection. The challenge about schools is really hard. And so I want us to keep in mind that our knowledge of this virus is about 6 months old. It hit hit the US February into March. And that is our knowledge of this infection. We also shut down schools across the US. And so we don't have any baseline US knowledge of the impact of schools on this infection. Okay, so huge caveat. And so when we talk about going back to school, we have to weigh the risks and the benefit. And one of the risks is safety. And we have to prioritize safety in terms of protecting our communities. And so what we know about kids is that they're not as symptomatic as adults. We know that they can get the infection, but probably at a rate lower than adults. What we don't have a really good handle on is what is the transmission patterns from a child to an adult or an adult to a child. We know it can happen. We know that a child can transmit an infection to an adult, and we know an adult can transmit an infection to a child. We just don't know how those rates compare to an adult transmission. Okay, so just brutally honest in terms of what we know. And so we really have to think about, how do we keep our communities safe? And it's not just the kids. And the biggest thing that we worry about is that you now have a congregate setting of children that, we know aren't going to wear a mask perfectly. They're going to try to wear a mask, but it's not going to be perfectly. What we worry about is our educators. What we worry about is our janitorial staff. What we worry about is our bus drivers. And keeping those people safe in the setting of schools is a huge priority, and keeping the parents and the grandparents safe of children that are in school. And so children that go to school potentially get the virus, go home, and could potentially transmit to maybe a sick parent or an elderly grandparent. Those are the factors we got to, really take into consideration. And we have to really put this kind of in perspective in terms of our case counts, both regionally and across the state. And so as we are seeing increases in cases, it's going to be really hard for us to say, yeah, we're seeing these really increases in cases and we're seeing our hospital capacity to being maxed, but it's safe to send our kids to school. Okay. And so I think really, and it'd be really interesting to have either Dr. Pavia or Dr. Hirsch or Dr. Thorell on here to talk about the specifics on this. I really think that it's going to be important for us to really demonstrate as a community that we can impact this curve and that we can decrease our case counts by doing universal masking, by doing social isolation, by doing, good hand hygiene, and drive those case counts down to where we were, maybe 200 cases per day or less, and then consider going back to school. If we are having these case counts of 600, 700, 800 cases per day and increasing, I just can't see a safe way for our kids to go back to school without continuing to perpetuate the transmission in our communities.
The case count thing is interesting too. So in March, when we originally shut down schools, the case counts were a lot lower, and now we're trying to go back and the case counts are a lot higher. So I think that's really interesting. And yes, kids need to go to school, they need to get an education, but what's the cost? And trying to figure out, does the cost outweigh the benefits? I know there's a bunch of districts currently trying to figure out what to do, whether it's online schooling, a hybrid of both. But yeah, I think it'll be interesting to see what happens. School starts in about a month, so we can kind of see what happens between now and then, and maybe things will get better and things will change. But we don't know, like you said. I also got a question.
The best we can do is, help educate those that are in those positions of making decisions for our schools and the Board of Education. And, we want to help them make decisions that keep our kids and our educators and our and our staff safe. And we're going to do the best we can to help them along the process of making a good, sound decision, considering safety. And that's really what we can do as healthcare providers is help them in that process.
We had a few questions specifically from teachers too. There was one teacher that was told that it was suggested to her that when she comes home from school this fall to take her clothes off in the garage, leave them there. Is that a good suggestion? I know this was something in March that we had talked about. Thoughts on that at all?
Yeah, so we know that the predominant mode of transmission is airborne, is respiratory, big, large droplets. That's the predominant form of transmission. There is a potential for transmission through contact, meaning touching things, then touching your face. That's why we really focus on hand hygiene. And so within Intermountain Healthcare, we have made recommendations to our caregivers, especially those that are taking care of patients with COVID-19, that when they leave work, they either leave their clothes at work and change and go home, or when you go home, immediately change your clothes, take a shower, and then engage with your family. That's our recommendation to our caregivers, just out of an abundance of safety. So personal story, I'm on the hospital service right now, taking care of inpatient COVID-19 patients and patients with infectious disease. So I'm in the hospital all day for the past 7 days. And I tell you what I do is I go home, I walk directly in, I yell at my kids, I don't see them, and I go right to the basement. I take a shower and change my clothes. I put my work clothes into a hamper, and then I go upstairs after showering and with clean clothes. It takes me 10 minutes to do that. And that's just out of a sheer abundance of caution. Do I need to do that? Is that going to decrease my rate of transmission from me to my family if I am either asymptomatic or pre-symptomatic? It might lower it a little bit, and that's why I do it. And it's not much of a sacrifice to me to be a little extra cautious. And so That's probably what I would say to a teacher, is that if you're having that exposure on a day-to-day basis with a lot of kids, I would, consider going home, immediately changing, showering, and then, engaging with your family.
What about N95s for teachers? If they are at a high risk, if they are in that high risk category, if they have an underlying health condition and they're still required to go to work,
Yeah.
is an N95 mask something they should consider investing?
Yeah. So probably not. What I would, say to them is that if they're at very high risk and they're, have additional concerns, I would consider a surgical mask, like a standard surgical mask, if they can, get one either from the school district or buy them themselves. I point this way because Costco was literally right there. Costco had them for sale last week. We know that surgical masks, when worn appropriately, decrease transmission of respiratory viruses. And so whether it be influenza, RSV, human metapneumovirus, we have decades of data to show that surgical masks decrease those risks. And so I would say if you can, I would wear a surgical mask instead of a homemade face covering, which doesn't have the same regulations as a surgical mask. N95s really should be maintained for the hospitals and our healthcare environments where we have aerosolizing procedures. So those that are undergoing procedures that forcefully take that virus and expel it into the air into small, tiny droplet or aerosols. And that's where we really want to focus our N95 use, is in those care environments. So in the ICUs, in the emergency departments where they're doing testing and people are coughing forcefully, that's where we really want to focus our N95 use. In the classroom, and presumably kids aren't coming to school symptomatic, a surgical mask would probably be most appropriate in that instance.
That's something important to note too. If you are sending your kids to school, and it does happen, if your kids are sick, symptomatic at all, please don't send them to school. Please keep them at home. It should be like that all the time. I've been seeing some things about masks and whether that just becomes a norm in our society, where
Right.
if you're sick, you wear a mask if you're required to go to work or wherever you're going. And I think the same thing should be considered with kids. Missing a day or two of school because you're sick is not going to probably harm you in the long run, but it could potentially harm someone else. So keeping an eye on your kids and making sure if they are symptomatic, you're keeping them home is going to be really important.
That point cannot be stated enough, is that if you or your child is symptomatic from a respiratory infection, that you do not send them to school. And what's going to be really hard is that we're going to be moving into respiratory season come November. And we know that when kids go to school, they get a lot of respiratory infections. And so we're going to have to be saying, hey, any respiratory infection, you really should not be sending your child to school because they potentially could have COVID-19. And so we're really going to have to work with employers to make sure that the expectation is, and that parents have the ability to stay home with sick kids, and that doesn't negatively affect their employment. And that is a huge culture change for us. It's a big culture change for us in healthcare, where we try to work through everything. If you're sick, if you have respiratory infection, you need to stay home to really protect the public and protect the community.
One more question about children with masking. Someone asked if you have any concerns about kids wearing a mask for 5 to 6 hours a day. There was a specific instance that she said someone she talked to was worried that their second grader was breathing in a damp, sweaty mask for 5 hours a day. Will you speak a little bit to that?
Yeah, I have no concerns for that at all. We haven't had any evidence that wearing a mask is detrimental to your health. Is it uncomfortable? Yes. Is it annoying? Yes. Do I enjoy wearing a mask for 8 hours a day while I'm up rounding in the hospital? No. But is it detrimental to my health? No, we don't have any evidence for that. And so it is safe, it's effective, and it's a cheap intervention. And these are things that just need to be part of our culture right now.
I know I'm not a child, but I did wear a mask, a cloth mask, on Tuesday for about 8 hours. And I was actually surprised at how easy it was for me. I haven't worn one for that long before, and surprisingly, it wasn't that bad. I feel like it's getting over this mental hump of I have something on my face. It can be constricting, but even teaching your child to maybe wear it for 5 to 10 minutes a day and kind of building that up will really help. And I know that has helped me, and now I feel very comfortable wearing a mask. And it's a cloth mask. It was homemade. It wasn't a surgical mask. So I think it's just teaching your children that it's going to be okay, and that if you wear one as the adult, then the child will probably reflect what you're doing as well.
Yeah, and I think it's important to start setting that example now, because if your child is not used to wearing a mask, and then all of a sudden school starts and they're expected to wear a mask for 5, 6, 7, 8 hours a day, it's going to be real hard for them. And so, you're absolutely right. Starting to set that expectation, starting to model that behavior, starting to use a mask for, even 5 to 10 minutes and then building from there is really important to do that right now, with the anticipation that they're going to need to wear a mask come late August into September. And it's a great idea to start that now. We know that, kids are not going to wear a mask perfectly. We know that they're going to mess with them. We know that there's going to be times where it's off. And that's just the reality of it. But, even just them wearing it when they can is going to be better than not wearing it at all. So it's something that we need to start working on right now.
Last question for you. Vaccine update. I know that there was some media stories yesterday about a vaccine that's being pushed through. Will you give us a little bit of update on how that is going, and if we have any sort of expected timeline on when we should see that vaccine?
Yeah. So, it's very exciting in terms of the vaccine development right now. The story you're referring to is the release of the phase 1 data from Moderna. Moderna is a small vaccine company that's working in conjunction with the NIH, and they have what's called an RNA vaccine. It's a new vaccine delivery type, which is very exciting. And they just released their phase 1 study results, which included 45 people. And in this study, they just said, is this vaccine effective in generating immunity, generating an immune response to the vaccine in these 45 individuals? And they used different doses of the vaccine, but each vaccine was given with 2 doses about a month apart. And the exciting part is that after the second dose, the vast majority of people that received the vaccines had levels of neutralizing antibody higher than those that were infected, prior infected, so using historical data. And so we are seeing that the vaccines, the 2 of them, which we have right now, both Pfizer and Moderna, are able to generate neutralizing antibody against the spike protein of SARS-CoV-2. And so that's exciting. It's showing that this vaccine is working in humans in ability to generate an antibody response. Now, the big question, the million, I guess it'd be more like $1 billion question, is whether or not those neutralizing antibodies are protective from getting infected with SARS-CoV-2. Okay, so that question of whether or not this vaccine is effective in terms of preventing infection or reducing the severity of infection, that comes with phase 3 trials. And so Moderna, Pfizer, and also Oxford University in conjunction with AstraZeneca are just starting their phase 3 trials. Sorry about the alarm. That's a hospital alarm that I can't do anything about.
Code blue,
we'll let that pass.
Suite 1, code blue, heart and lung, angio.
This is just real life.
That's just part of being in the hospital. So that effectiveness of the vaccine will be determined in phase 3 trials. And so those trials are either have started just recently or are slated to start this week or the end of July in terms of the Moderna study. Those studies, based on the FDA guidance, are going to need about 30,000 people in each study and 6 months worth of data. Okay, so if they start, let's say, the end of July, they're going to need August, September, October, November, December, January, 6 months. So at the earliest, if they enroll quickly, if they get 30,000 people in each study, and they get to the 6 month mark at the end of January, that's when they can make a determination of whether or not that vaccine is effective in reducing either the infection or the severity of the infection. Then it has to go through the FDA approval to get emergency use authorization. and then it has to be distributed across the globe. And so best case scenario is if this shows to be effective, any of these 3 vaccines that are starting, I think beginning of Q2 is probably Q2 of next year. So probably April of 2021 would likely be the earliest we would be seeing vaccine being delivered to the United States to be used in the highest risk people. So that would be healthcare workers and those with underlying comorbidities that put them at risk. We're on track for that, but that assumes that the phase 3 trial is going to show that it's effective. And that's a big if. Now, these companies are putting huge gambles on their vaccine being effective. And so what they're doing, and this is the way that we can shorten the time period of development, is what they're doing is that they are starting manufacturing of this vaccine at the same time that they're starting their phase 3 trials. And what they're banking on is that they're banking on that their vaccine is going to be effective in phase 3 trials. And if it is, and it gets FDA approval, then they can start distributing immediately. But if it's not, they've just lost billions of dollars in terms of vaccine manufacturing. And so that's a big gamble, but a gamble that it's worth doing because of the impact this virus has had on our communities. Hopefully
we just got a question about vaccines specifically too. Can we trust taking a vaccine that's being rushed, or could there be side effects down the road a couple of years from now?
It's a really good question. And, that's why the FDA is putting in, some of these minimum mandates of at least 6 months of follow-up. Okay. Keep in mind that some of the vaccines that we've developed has had side effects, and some of these side effects are very, very rare. Look at the rotavirus vaccine and causing something called intussusception. That was something that was only seen after hundreds of thousands of people got vaccinated. And so some of those rare side effects aren't known about until years later. And so what we're going to know is we're going to know the short-term safety of this vaccine, because we're going to have at least 6 months of experience with this vaccine. The vaccines that are currently coming are called RNA vaccines. So they're not any live viruses in them. They're just an RNA segment that your body takes in and produces the protein, and then we generate an immune response to that. But we will have 6 months of safety data to be able to rely on. Longer term safety data is really going to come through what we call kind of phase 4 or post-marketing surveillance of a vaccine. And that's going to take a little more time. There won't be an emergency use evaluation approval for a vaccine unless they pass the safety rigor of the FDA. But that's a 6-month window. But I anticipate that these vaccines will be safe. And the FDA is going to be, keeping an eye on these things very, very closely to ensure that we're not, widely vaccinating people with a dangerous vaccine.
It's good information. Eddie, is there anything else you want to mention today before we end the live?
Yeah, I just continue to do what that will improve public health, and that's stay home when you can, reduce your close contacts, and if you do have to go out, wear a mask in public where you can't do physical distancing or where you're engaging with a lot of people, and wash your hands. Those 3 things, it hasn't changed. The message hasn't changed. And we really hope to see case count starting to level off if our communities can really get behind these things. And I know it's not a state-based mandate. It just has to happen, though. We really need the community to help us. Right now, our hospitalization levels are stable. We would love to keep them that way. Our caregivers are tired, they're stressed, they're nervous, and they want to be able to provide the best care that they can to our patients. And I can tell you, after seeing these patients, you don't want this infection. This is not an infection that you should just go out and get it over with. This is not a pleasant experience. So do what you can to avoid getting infection and really help out the community in terms of, good public health measures. This isn't political. This is by no means any kind of, shouldn't have any political divide amongst it. This virus doesn't care what political party you're in. We just need to band together and really kind of show our loyalty to Utah and our loyalty to the US in terms of saying, yeah, we're gonna do this, we're gonna bend the curve, we're gonna become stable again, and we're gonna create an environment where our kids can safely go back to school. And for us to do that, we gotta rally together and really, put a mask on, stay home, minimize your contacts. That's it. You've heard me say it before, Amanda. I'm gonna say it again.
Wear a mask.
Wear a mask.
Eddie, thank you so much for joining us again. And a couple of phone numbers really quick for you guys. If you would like to get screened for COVID-19, you can call our hotline at 844-442-5224. They will run you through some questions and give you some locations that you can go get tested if you qualify. We also still have our emotional health relief hotline available 7 days a week from 10 a.m. to 10 p.m. That phone number is 833-442-2211. We also have our online symptom checker available at intermountainhealthcare.org. It's located in the bottom right-hand corner. It'll run you through the same questions our hotline will and tell you what type of care you should receive. Eddie, thank you again so much for joining us, and we'll talk to you next week.
Thanks, Amanda.